This is the AAOS Career Podcast, part of the Bone Beat Orthopaedic podcast channel. This monthly series features conversations on professional development and growth opportunities within the field of musculoskeletal healthcare.
Hello, everyone. I'm Ellen Lutnick, Chair of the Resident Assembly Executive Committee, and this is the AAOS Career Podcast. This episode is designed to help our listeners prepare for and pass their boards, specifically highlighting Part 2. Joining me to offer perspective is Dr. Alexandra Page, a foot and ankle orthopedic surgeon in San Diego, editor-in-chief of the AAOS Now, and a former board examiner. Dr. Page, welcome to the Career Podcast.
Oh, thanks so much, Ellen.
Thank you so much for being here. I wanted to start by asking you a little bit about your experience with the AAOS, because you are a former board examiner. What your background was with that and kind of what led you to being as involved as you were when you were involved?
Well, I actually want to start certainly by explaining some of my limitations, if I may. I have been honored to have spent many years as a Part 2 examiner. I am not, nor have I ever been, a director of the AAOS. So certainly nothing that I say should take precedence over what's available from the AAOS and their website. In terms of how I got into it, honestly, it was sort of by accident. Certainly, as all orthopedic surgeons, I've been through the process, through Part 1, Part 2, and even what was then Part 3 when you recertify in the old days. And I was on a committee with someone who said, "Hey, have you ever thought about being a board examiner?" I hadn't. I'm not in an academic setting, but I pursued it, and I have to say it has been a very rewarding part of my career.
That's awesome. And you mentioned in our email correspondence and then now even about how you were not coming from an academic setting and how that is sometimes a misconception with regards to being involved with the AAOS and becoming a board examiner. I think people, and I think I even assumed that, it's more these academic programs or people that are more involved in academics that might be involved in that process. But that's great to know that that's not necessarily a requirement. Are there any other specific background or qualifications that people need in order to become a board examiner?
Yes, you need to have at least undergone your first, what for me was recertification, but is now that first cycle of continual certification. So you're at least 10 years out from passing Part 2 before you'd be eligible. You're vetted by the AAOS, and you have to be in the active surgical practice of orthopedics. I am no longer active in surgery, so having given that portion of my career up, I'm no longer eligible, unfortunately, to serve. But I think that does a great thing in terms of making sure that you are examined by people who understand what it means at this time and in this environment to be in the operating room. So I think that's important. And as you mentioned, even though when I was on the board, when I was an examiner, my fellow examiners included people who are luminaries in my field. I'm a foot and ankle subspecialist. I came from a background of practicing mostly in a very large managed care environment and then in independent practice. And I think that reflects really the more common types of practice of folks that we're examining. So it was important to me that the AAOS respects that perspective that I brought.
Yeah, that's great. And it's also good to know for people that are going to be sitting for their boards that this is meant to be kind of their peers that are asking them these questions and interpreting how they took care of patients and the cases that are being presented, and not just people who are, maybe from different environments and that are not as familiar with the process of what they might be going through on a day-to-day basis. In your experience as a board examiner, what was that like for you? What aspects did you enjoy? Maybe what aspects did you enjoy less? Or are there other parts of the role that you want to highlight potentially for someone who might be interested in pursuing that as part of their career or options to be involved with the AAOS?
Well, I would say that I've been very active in professional life. I've been the president or on the board of multiple professional societies, and of all of the work and all of the effort that I have given to the profession of orthopedics, being a board examiner was hands down my favorite. From my perspective, the opportunity to be involved with the other examiners, to form those relationships, as well as the give and take with the examinees. I have to say, I learned things from them as well. I also believe that perhaps in a more concrete way, that week that I gave up every year to be in Chicago had a more meaningful impact on the profession than anything else that I've done. So from that perspective, it's down the line for people who are listening to this podcast, but it'd be a great thing to think about. in your future.
Yeah, that's a really good way of framing it. It's also, I think, hopefully, not that people think about the AAOS as something to dread, but I think people do tend to dread the boards coming up. It's a stressful time. It's a lot of preparation. It's a lot of, there's a lot riding on it. But that's, the flip side of that is there's people sitting across the table from you who want you to be successful in your career and want you to take good care of patients and want you to get that certification so you can go out and do good. And it is a very impactful, I can imagine, way to steer the path of the orthopedic field in general. That's really cool. With regards to kind of understanding the exams, I am a chief resident, so I'm coming from maybe the start of that consideration. But our audience for this podcast tends to include trainees at every level. So maybe for myself and for others who are early in their training who might not be as familiar with the board's process, and especially the Part 2 process, can you explain what that entails based on your experience, just for some background?
Sure. Just kind of as a high level view, there are really, I think, 3 parts that you ought to consider. The first is Part 1, which is probably staring Ellen in the face pretty hard. That's usually taken right after your residency, or some people take it after fellowship. That's a computer-based exam. Part 2, which is really what we're going to focus on, is a multi-step process that really assesses your practice. And that's the whole of it, is not just to know what you know, it's to understand how you practice. And then the final part is the maintenance of certification. And that's ongoing. And I think that is an important aspect that I will try and bring up as we talk about Part 2. But really, if I had to think what the AAOS is about, in their mission statement, they talk about wanting to ensure the safe, ethical, and effective practice of orthopedic surgery. But that's lifelong learning. And it's not just learning from meetings and journals. It's also learning by assessing your own practice and making it better. And I think that's really at the heart of Part 2 and really the maintenance of certification.
Yeah, that's great. So in the process of understanding how you practice then, with regards maybe to more of the nitty-gritty details, you mentioned Chicago. From my understanding, you submit cases. There's then cases that are accepted by your examiners or selected by your examiners, and then you actually show up in person and talk through those cases and answer questions related to how you took care of patients. Is that an accurate assessment of kind of what we're working with? Right.
That's an accurate assessment. This is a big deal. And you probably, if you know people who are young attendings, they're talking about it, because it's unlike showing up at a testing facility and being stressed about your knowledge. Here you're showing up in Chicago in the summer, having to negotiate TSA and everything that comes with that. But that represents the last step of what has been almost a 2-year journey to get there. So the oral exam, is as frightening as it is to sort of think about sitting before a jury of your peers, some of whom are the senior authors on the papers that you read to prepare for it. It's that it began 2 years ago, and it really reflects those multiple different aspects of your practice. And the reason that it may seem like why are they just throwing these things here? Are they just doing it to be punitive? No, it's not. And I'd like to, if we have time, Ellen, can I call out some of the different parts of it so that people understand why they're there?
Yeah, absolutely. I would love that.
So it really begins almost 2 years ahead. There's a period of time that you have to be 17 months that you have to be in practice with continuous credentials at a hospital, surgery center, all those places. And that's because they need the continuity. And that can become a challenge for folks. So you need to really recognize those deadlines. But what that does is, by tracking what's happening over the whole course of that time and doing a 6-month case list that goes in that second year, tracking every single case, they are looking at how you handle your patients, how you do your initial workup, what your ability to order and interpret additional studies, what your surgical indications are, how you do a surgery, how you follow them afterwards. It is that real 360. So that's the case list that you have, as well as the 12 cases. And we'll kind of talk about the difference between those. The 12 cases that you actually present when you come to Chicago are very important, and we'll get into hopefully more detail on that. But in addition, there are other components. One of them is peer review. And it's a pretty high bar before any surgeon in the community, even if you're young and they're mature. It takes a lot for anyone to say, hey, you got a problem there. But you are required to submit the names of AAOS certified surgeons who would be acquainted with your practice, so that they have an opportunity to basically weigh in. And if there's a problem, that is something that can be alerted. This happened. This goes to the credentialing committee. This goes to the directors of AAOS. In addition, you need to have letters, not just from your department chair, but also from the chair of surgery, from the ER, from OR nursing. And that's an interesting perspective to have that you often don't get. When you're kind of trying to find your role, transitioning from being a resident or a fellow into being an attending, what feels like being assertive to you could be seen as being arrogant or disruptive to others. And so this peer review certainly is an opportunity for you to learn some of those things. I hope that for nobody listening, that is an issue. But this is a chance to understand if you are practicing with the professionalism that's expected. The way you treat the chair of your department shouldn't differ a whole lot from how you treat an orderly who was wheeling your patient from the ER to pre-op. That's part of this process is teaching us that professionalism is about how we treat everybody in our sphere. The final one, which is actually relatively new, is collection of patient-reported outcome measures from your patients. And this, I think, really is a reflection on how orthopedic surgery is, and all of medicine, is going to be practiced. There's an expectation that your patients are filling these out. Your reimbursement's going to be based on them. But I think as well, it's very important for you to know if your surgical indications are good. Are your patients doing well? If somehow those degenerative knees you're scoping aren't doing really well, maybe you should rethink your indications. So from that perspective, I really would encourage that folks who are preparing for this see this as a chance to set themselves up for how they're going to be living their lives as orthopedic surgeons. Everything from how you chart to what your surgical indications are.
Yeah, it's great to see that from the bird's eye perspective. I think we have a couple of young attendings in our practice now that are kind of going through this process and either in their boards collection period or coming up on their, date where their cases are being selected. But, it's not just how good of a surgeon you are, how you can take care of patients. It's also how you present yourself in that professional sphere and how those things are weighed kind of all together in one bigger picture. With regards to, complications happen. We know this as surgeons. We know this in surgery. We do our best to avoid them. But obviously, I think someone in their boards collection is probably going to be that much more anxious about a complication even than someone who's not. She's like, oh my gosh, did I do everything right? Did I, follow exactly, what I've learned in the literature and from my fellowships and from my residency training? Did I do my best by this patient enough to be assessed, under this potentially a microscope by a jury of my peers? How is patient safety actually assessed during part 2? There's patient-reported outcome measures for outcomes. There's the actual indications and what you're doing in the surgery itself. But is that a component that's considered? I would imagine it would be.
It is. And that's absolutely, I think we can talk now about complications or later, because I think that you've kind of gotten on one of the biggest fears that a lot of folks have. Like, oh my heavens, I have complications. Yeah. Well, yes, you're a surgeon. You're going to have complications. Patient safety, I think, is very much about reviewing those case lists and the peer reviews. Again, we talked about how peers who truly think you're an unsafe surgeon, it may take a lot for them to say something, but in a more anonymous setting like a peer review process, it would come out. But the review of the case list would be a place where we see this. And we all understand that happens, but there is a standard of care. And so if you're demonstrating unexpected complications, things that we know about what the rate should be for complications in clean cases, we know about nerve injuries, know these things. There are some things that are unexpected and they're higher than expected rates. And those would be things that might be a red flag.
Yeah, absolutely. So it sounds like, if you are in that boards collection period, hopefully this is reassuring for people. If you come across a patient and there is a complication in your treatment plan for this person, it's less about the complication happening as long as you're following the standard of care and doing your best by that person and not outside of what might be reasonable to expect in that surgical setting or in that treatment setting. It's less about the actual complication itself and what led you to that point and how you handled it.
That is absolutely right, Ellen. And I would say that one of the things, in fact, I think that if you have no complications, that's almost a red flag. It happens. The most important thing is, do you recognize it? Do you first, I guess, before even recognizing is, are you doing the appropriate things to avoid them? Patient selection, optimizing patients for surgery. Are you making sure they get prophylactic antibiotics? Are you doing appropriate VTE prophylaxis? All of these things are prevention. Then there's recognition, and then there's rapid treatment to address it. So those are all part of what we look for in terms of whether you are practicing in the standard of care in the way we would want you to practice as an orthopedic surgeon. So it's much less about expecting perfection. We don't expect you to be perfect. I think one of the reasons that you have mature examiners is we're all mature enough to know that complications happen. What we're looking for is how you address them and minimize them.
Yeah, that kind of speaks to my next question. So you have this experience being a boards examiner. This is kind of an opportunity for myself and then also hopefully for our listeners to get a peek into what that perspective is from the other side of the table in the Part 2 exam. So beyond what we just talked about, how you manage these things and how you handle things appropriately leading up until maybe a complication, what is it that examiners are actually trying to assess in the exam beyond just a candidate's medical knowledge? What is it that the examiners are looking for in that setting?
So you take the in-training exam, you take Part 1, that's all about knowledge. So we kind of take that almost as for granted that you have good knowledge by the time you're sitting for Part 2, although we'll talk a little more about how that envelope might get pushed. But it's a lot less about facts and it's much more about your capacity for problem solving. For example, are you listening to your patients and really doing a targeted exam? Obviously, you have to document that. Do you understand what the differential diagnosis is for that knee pain? And are you taking the next step to get the appropriate diagnostic studies if necessary? And then once you have gone down that path, was your choice of surgery appropriate? Certainly, was it well executed is a big part of it, but there's a lot that leads up to the OR. I think everybody tends to really focus on, my x-rays, my heavens, that screw could have been a little shorter. Was my version exactly the way it should have been? But there's a lot that leads up. Remember, orthopedic surgery, like all of medicine, is a practice. We know where we really hope that by the time you're a few years out of fellowship, you haven't reached the apex of your clinical and surgical skills. But we hope that you are doing all the steps that it takes, because if you're not taking good history and you're not doing a good physical exam, you will never be a good surgeon, regardless of how your clinical skills or your operative skills may improve. Does that make sense? And I think we talked a lot about also in that practice and in the decision making, when a complication does occur, it's about how you address that.
Yeah, absolutely. That makes a lot of sense. And I think people do kind of tend to focus on the operative cases and the documentation of those operative cases, when in actuality, it is kind of that bigger bird's eye 360 view of your overall patient care and how you've approached things. So when you were evaluating a candidate in that setting, in the actual exam, what were some signals that maybe reassured you that a candidate was competent and safe based on, your perspective beyond just reviewing their cases and kind of what they did, but how a candidate maybe presented themselves in the exam versus red flags that were raised in the actual exam process?
Ellen, I'm going to use this actually to pivot just a wee bit, which is to call out the AAOS website. The AAOS is there to support you in this process. I don't want people to think that there's something that's like the Death Star that really just wants to create pain for you. Not at all. Yeah. And so there is a huge repository of information, and your first stop for sure should be there to get to know everything that's on that. And the reason that I'm mentioning at this point is that among the resources that are on there is a scoring rubric. It is an actual sheet that lists the scores that we use. It lists the specific criteria that the examiners are expected to use when they score each one of your cases. So basically, it's sort of, I won't say it's exactly the answer sheet, but it's not like it's a mystery what we're looking for. It is there. And that is what you should be using when you go through your sheets. It defines. There are 4 scores. You get a 0, 1, 2, or 3 on each case for each of these domains from each examiner. And that is what signals to us competent or safe. Someone who is a 2 or a 3 is doing the right thing. Someone who's a 0 or a 1, there's a problem. And for each of these domains, you can kind of really target it. I would say, in addition, how well prepared you are is kind of a proxy for how well you prepare as a surgeon. I mean, when you're a young attending, it is a busy time of life. I understand. I've been there. Not only do you have all of the demands of being new in your practice, trying to get settled, probably, many often have a young family, have all of these other things happening, financial stresses, but if ever you were going to prepare for a big case, this is the big case you prepare for. So people who are not prepared, that's a little bit worrisome. But otherwise, things like really understanding that you have done the data gathering, that you have looked at the differential diagnosis, that you have a treatment plan, that you executed that treatment plan. Maybe there was hey, your screws could have been a little different. Maybe you say, oops, I probably should have done things in a different way. It's about recognizing and responding to the information that you have and making those choices. So that's really what reassures us that you're competent and you're safe.
Yeah, that makes a lot of sense. And it's very helpful to kind of point people to the AAOS website. I know even at the Academy annual meeting, there was a talk for chief residents and like early kind of graduates of residency. And one of the talks was about the AAOS. So I've seen that rubric before. And it isn't like there are some websites out there for professional societies or for different programs that are maybe less cohesive, but the AAOS resources truly are, someone's put a lot of thought into it. Clearly, there's a lot of stuff there, and it's very well organized, and it sounds like on par with what is actually expected of you as a candidate, which hopefully, again, is reassuring to people who are listening to this. I know for me, reassuring. So on the flip side of that then, so based on our conversations prior to this podcast, you did mention that you and other examiners don't actually know what the final outcome is for candidates with regards to final decisions to pass or fail candidates. There's a lot of transparency, it sounds like, and it seems like from the AAOS resources and website leading up to the boards. But what is the purpose of this lack of transparency kind of on the flip side of things after the exam?
I think it's sort of twofold. Number one, we really want to respect the professional integrity and privacy of the candidates. And so that information is really held by the directors. So I think as much as we as examiners were held to a high level of professional integrity, they've got another step up above that. But the other very important thing to recognize is that each examiner is really handled as an independent entity in this process. So you are examined by 4 panels of 2 examiners each. So that's a total of 8 examiners, and each one independently, we don't confer, independently rates each of your 12 cases on those 9 different facets on the rubric. So that gives you well over 200 individual data points. Those are then taken and statistically analyzed. They do an analysis of the varying strictness of the examiner based on leniency or strictness, so that those are all normalized. So by the time it's done, it is very much about a more complex, comprehensive view of your entire practice, not just the 3 cases that I might have looked at as an examiner or my prejudices about whether you chose to use one technique or another. And that's part of it, is that it divorces any individual examiner from the process while respecting the privacy of the candidate.
That makes a lot of sense. When it comes to preparing for the oral examination, part 2 is taken after training. You mentioned early attendinghood, being a young attending is a stressful time of life and a busy time of life, just regardless, but then also in addition to preparing for boards, you have a lot more responsibility. Do you have advice for candidates who are in that process or about to be encountering that process maybe for holding yourself accountable to preparing for your boards, for studying for your boards, especially for part 2, and then any additional resources, even beyond the AAOS resources that you've already highlighted, that people might find valuable, especially for those of us who might be used to group study or a grand rounds type format that maybe is less accessible now, depending on what people's practice looks like after training?
I think the best thing to do is to get a study buddy. And not just because, not studying, making flashcards. What you're doing now is you are actually looking for one or more colleagues who are maybe at the same stage you are. This is where you go back to your folks from residency who are all preparing for the boards at the same time. There are other hopeful networks if you're involved in something, for example, people that you may have met through the resident assembly. That would be a resource. So other people who are at the same stage and are going to be willing to give up the time. In an era of Zoom, you can basically give each other an oral exam. What I would suggest is that you take the time, you prepare your cases, going kind of point by point down that rubric, and then you give that exam to your residency buddies and ask them to be rigorous and hold your feet to the fire and say, oh, well, you really didn't tell me what your thinking was there in terms of the differential diagnosis, or why did you choose to do an IMHS instead of doing a sliding hip screw? So these are other people who may not be in your subspecialty area, but they may know enough about, you're not that far out from residency that they can actually comment effectively. And you do it back and forth. Additionally, you want to find somebody who is in your subspecialty area. If you're going to be, my area is foot and ankle, I would have gone to someone who's an attending who's been through the board process, someone who's not an examiner, because we're not allowed to give mock exams, but somebody who's been through the process and how to say, well, you might want to think about this, or if you made that decision, you should be aware of these other choices. Why do a total ankle and not a fusion? So both of those, I think, are extremely effective ways. And this is something where you have to get up and talk it through. Even people who are very facile with public speaking, it's a different process. And I think that people who are very comfortable with presenting the case and thinking it through will find it's an easier time. But more importantly, having other peers push you is where you will think of things that you need to go and look up. And that's where the independent study comes in, is that, I thought I knew why I made that choice, but, I don't always use aspirin for VTE prophylaxis. What really are the indications to go to a different choice? And making sure you know that literature. Those things that keep coming up in your practice, you should be acquainted with the literature on. And that's where you go and do that extra bit.
Yeah, that's really helpful and great advice. I can think of probably one or two co-residents that I will be very much looking forward to bothering when that time comes around for all of us. In your opinion, what distinguishes a strong oral performance in that set and setting, taking the actual exam, from one that's maybe average or more subpar?
So I want to kind of disconnect the two aspects. One of them is the oral performance. And it's great to have someone who's a smooth talker and very facile and really knows their things. But a good performance can be completely disconnected from a good surgeon. So that's the onus upon the examiner, is to not look at the performance or not look at just how good a speaker you are, but to really understand your thought process and your practice. So for those folks for whom it's just not where you shine, don't be as concerned. But you may need that extra hour in there to prepare so that you feel comfortable going. But if we go point by point through that rubric and we're saying, yes, your diagnostic skills are where they should be or above it, your surgical indications are on spot, those are the above average. The ones that are subpar, some of those are pretty obvious. A red flag, like someone who either doesn't recognize a complication or who fails to appropriately treat it. Those are things that no amount of oral performance can make up for.
So encouraging, I think, in a lot of ways, maybe for people that are more anxious, just being in front of, a panel of examiners and actually representing how hard they've worked over the last 2 years. It's less about your ability to vocalize that and more about your rationale and what you actually did and how you can represent that authentic to yourself and to your practice. That's really helpful. In general, how do you tend to evaluate clinical reasoning versus memorization? Maybe, people come in and they've really prepared and they did their, practice with their previous co-residents, but then also looked things up, people who are quoting studies versus people who are rationalizing how they're treating patients and kind of walking through the process of treating a patient based on that more clinical reasoning. How is that weighed separately or together?
Quite clearly, the clinical reasoning is more important. Again, versus the memorization that you get when you're in the in-training or in part one, it's understanding how you take data and what you do with it. Number one, what data you collect, and then what you do with it. So one of the ways in which we can do that certainly is, once again, you're going to hear about that rubric, kind of seeing what you do and maybe asking questions. So when you think about your presentation, we want it to be succinct because time is a factor. There's a time limit here on how much we can ask, but we also need to hear the pertinent negative. What you choose to present says something. I don't need to know all the lab values, but if they have a hemoglobin A1C of 11, I want to know that. And you should recognize that that's an important part of the history to present. Yeah. Similarly, the physical exam, I don't need the normals, but I do need the critical parts of that exam and the pertinent negatives. When we look at clinical reasoning, I don't want you to just sort of throw up an MRI and say, and then it showed, with the impression that all you do is read what the radiologist report is. The clinical reasoning is that you can point to the salient findings on the imaging studies. Probably one of the important ways that can be teased out is that what happens if we change a variable? For example, you chose to make this decision for a patient, but what if instead of being 32, that patient was 65 years old? How would that variable have changed your decision making? And we talked earlier about VTE prophylaxis. What factors would have made you decide that you needed to go with warfarin or with some other VTE prop? So changing a variable in your case can be a way to kind of tease out reasoning versus memorization. At this stage in your career, chapter and verse from every article you've ever read is meaningless unless you can see how that applies to the patient you are treating right now. And that's when we talk about understanding your practice and your ability to collect, synthesize, and then transfer that knowledge base into effective orthopedic surgery. And finally, evaluate yourself and move forward and move onward.
Yeah, absolutely. That's very helpful advice, I think, and a good mindset to go into your exam, timing how you're going to present things in that way. Obviously, we've talked already, board examiners aren't looking for perfection. They're not necessarily looking for a practice that is completely void of complications. But let's say there's a candidate who maybe answers a question wrong or makes a mistake in the actual oral exam. Do you have advice for how to recover from that, or advice for someone that hopefully doesn't find themselves in that setting, but maybe someone who does?
Well, I would say on that question that the answer for giving the way to treat giving a wrong answer in your boards exam is the way to treat giving a wrong answer anywhere in life, whether it's in the operating room, with a patient, with a spouse or partner. As soon as you recognize that you gave a wrong answer, whether it's in the moment or 5 minutes later and it comes to you, admit it. Say, oh my heavens, on that last case we were just discussing, I realize I told you that was wrong. If you happen to say the correct answer was, that's great if you can give it. But acknowledging the error, having the humility to say I was wrong, and then to say, I should have known the answer to that, and honestly, I don't, is going to get you a lot farther. It's going to get you a lot farther in your oral exam. It will get you a lot farther in life, and it represents that you understand your limitations and you are going to grow forward and get that answer. So I think that you shouldn't worry about a wrong answer. If you recognize it, that's great, and absolutely acknowledge it. If you don't, there are multiple data points here. The fact that you didn't know the metallurgy of the knee replacement that you're using, well, when the question was asked, you might find that you'll go look it up afterwards. But there are multiple data points, so don't worry over a single wrong answer.
That's very helpful, and hopefully, again, also encouraging. I think the theme of this podcast is hopefully be a little bit less anxious for your boards. They're truly meant to be on your side, even if it seems like a stressful time. I guess on that theme then, so in the context of a strong answer, not all of medicine is clear cut, black and white. This is a very obvious diagnosis and there's a very obvious perfect treatment. In fact, I think most things do not play out that way. What role then does acknowledging maybe uncertainty in a differential or in a treatment plan or in managing a complication play maybe for a candidate who is going to answer strongly?
I think uncertainty is really a key part of this, and you've really hit on something. When you're in residence and you're taking an in-training exam, there is a correct answer. Mm-hmm. Uncertainty is the hardest thing that we deal with, and that is really where grace under pressure comes in. We talk about medicine as an art. I think it's easy to want to say orthopedics is much more of a science, but in reality, it isn't. And back to having more mature examiners, we for darn sure know that that it is an art and it's continually evolving. You have to at some point make a choice. You have to make a choice on imperfect information. You collect as much information as is reasonable, but there's a point at which collecting more information isn't going to help you anymore. It's cost prohibitive. It doesn't help the patient, leads you astray. So you have to make a choice. You hope you made the right choice, but what's most important is that you understood the choice you had to make. You collected as much information, and the information you had led that to be the best decision that you could make at that time for that patient. Sometimes choices are wrong. Poor choices lead to experience, and experience, I think, leads to better choices. And that's the pattern of lifelong learning. It's not just about read another article, go to another meeting. It's about looking at the choices you made and making a better choice next time if that was not the best choice. So absolutely, uncertainty is the difficult part of anything in life, but certainly in being a surgeon. So back to talking about complications, it's at the edges. These are the parts that really would tell an examiner how you function under stress. Yeah, everybody can do a straightforward carpal tunnel release or put in a knee in somebody who doesn't have any malalignment. What happens when the going gets tough? What happens when there's uncertainty? How do you deal with that? Are you thoughtful, rational, safe? And even if it ended up perhaps not being the best choice, have you learned from that? And therefore, the next time you will make a better choice. Those are critical factors for you to be able to provide good, safe, ethical, effective orthopedic care for the next 30 years.
Yeah, I think a lot of that comes out even in residency, when you talk to some of your more senior attendings that have, maybe been around the block. It's one of our attendees, the more you know, the more you realize you don't know. And it's not to say that there isn't a correct answer sometimes, or the same attendings maybe who are like, oh, you should come to clinic more and see how these patients are actually doing. Like, what level of pain post-operatively is actually a red flag that something is truly wrong versus a patient who has a lower pain tolerance and this is expected. The kind of things that come up that are less clear cut than just, oh yeah, there's a femur fracture, we should probably fix that. In the context of the oral presentation, then, from a more granular standpoint, what does a well-organized case presentation sound like or look like to an examiner?
Once again, you're going to hear this like a broken record. That rubric really kind of tells you the points you want to hit. You know that the examiner is going to be listening for each one of those things about data gathering. And data gathering is the history the patient takes. It is the labs that you think are relevant or that aren't relevant, or the imaging studies that are or aren't relevant. Why did you not get an MRI scan? Well, because all of these things that I didn't need to. A well-organized study is going to include those pertinent negatives. And I think that's something, it's a middle of the road. It's not the bone broke me fix, but it's also not every single thing that Epic imported, including the 75-page infectious disease consult. You recognizing those pertinent facts and including those are what represents your understanding of what are the important data points. And then being able to formulate your data plan, including, as you said, owning up to uncertainty and saying, I could have done an ORAF, but I felt for this patient, for the hip fracture, given the level of activity, but the age, that it pushed me to want to do a total hip replacement. When you have a choice, make sure it's clear why you made the choice that you did. So that tells me that you're hitting on the points that I need to hear about your ability to get the information you need, process it correctly, obtain additional information if needed, that you're developing a treatment plan, and then that you're executing it. Also, at the beginning, I sort of touched on how this is a time for you to really look at your notes. And this is something you want to think about beforehand. And if, for example, you're in an academic setting where you've got residents storing your notes, or if you are working with a PA and they're doing a lot of the things, this is a time when you want to make sure you recognize what are the critical parts of your interaction with the patient, and you're taking ownership of those. As time goes on, you spoke about how when you're going to clinic, you have a better understanding after you've been years and years, and you can more effectively allocate some of those tasks to other members of your care team. But during this time, you probably want to take ownership of a lot of that. Yeah,
definitely. And I think that speaks a bit, as a trainee working with some of these newer attendings who are maybe in their boards collection or coming up on their boards collection period. Some of those attendings, you can see it in their practice patterns. Like, they want the last hands on the patient in the operating room. They want the last hands on the note in the clinic. They want the last hands on the consult from the emergency room. And that level of attentiveness to detail, always when you're taking care of patients, especially when you're working with trainees, but especially in that time period, really just trying to make sure your ducks are in a row. I guess maybe to start to wrap us up here, if there was one takeaway that you would want people to have, whether or not they're residents that are, thinking about the oral exam in a few years after fellowship, fellows who are thinking about early practice, early practitioners who are coming up on their boards collection or in their boards collection, thinking about their Part 2 exam, what's something reassuring maybe that you can offer? I think there's been a lot of reassuring things already in this episode. And then maybe what's, a pearl of advice that you might have for those people?
Well, I think the reassuring thing, as you said, I would like you to think about the AAOS as an ally, as a career-long ally in helping you become the best orthopedic surgeon you can. And using each of these processes, part 1, part 2, maintenance certification, to work with them to really optimize your practice. And I believe that that's really at the heart of that. So I think that probably the folks who are taking the extra effort to listen to this podcast have already pre-selected as likely being people who are going that extra mile. And I hope you will go that extra mile throughout your process. In terms of a bit of advice, I would say, for sure, stay on top of the AAOS website. Reach out to your ABS, see if everyone's assigned by their last name to a particular person who's going to have a ton of background knowledge. But there are lots of things in there. For example, we always think of this in-person being in July because that's when we've always done it. But they actually have an alternate date. If you have a life event that conflicts with that, they will accommodate you. There's an alternate date in October. You need to go through the AAOS, but they would support you with that. Similarly, all of this information is on the website. Don't miss the deadlines. Recognize you need to start thinking about part 2 years ahead.
Yeah, that's great advice. Dr. Page, thank you so much for sharing your insights and for helping our listeners understand what to expect and hopefully provide some reassurance and advice in general to prepare for their boards. I do want to plug the AAOS website one more time at www.aaos.org, which is where a lot of Dr. Page's references are coming from. So I know that I'm going to be heading there shortly to make sure that I have my ducks in a row and using that as a centralized resource. But thank you so much for being here with us tonight.
Thank you, Ellen, and good luck on part 1.
Thank you.
Thank you for listening to this episode of the AAOS Career Podcast, part of the Bone Beat Orthopedic Podcast channel. Production and editing provided by MK Quinn Media. Check out the video version of the podcast on the AAOS Career Podcast YouTube channel. To hear other conversations on professional development, please visit aaos.org/thebonebeat.